Chairperson, my colleagues and my juniors, I am presenting our works on Z-palatoplasty, the Indian scenario. I am Dr. Sudipta Chandra. I am working at Bellevue Clinic and Hospital. This is the hospital, and my presentation starts after lunch. It is on the snoring surgery. Please do not snore. So we all know what is an obstructive sleep apnea. Just an introductory video. So this is what happens when we sleep. Normal breathing, then the tongue falls down, the palate loose and lax, then there is obstructive breathing pattern.
Or a hypopnea, in addition to snoring and ultimately sleep fragmentation.
So these things continue. Then there are 5% of adult population have obstructive sleep apnea. 18 million people suffer from sleep fragmentation.
Daytime sleepiness. Left untreated, long-term effects.
There are many long-term effects like hypertension, stroke, cardiac arrhythmias, myocardial infarction.
Short-term effects include
There are short-term effects like decreased quality of life, excessive daytime sleepiness, restless sleep, poor judgment and concentration, morning headaches, irritability. Now, as per the Mayo Clinic guidelines, this is the management guidelines of obstructive sleep apnea management and hypopnea syndrome. In mild, like apnea, hypopnea index 5 to 15, first we go for the lifestyle changes, weight reduction, quit smoking. And in moderate, that is 15 to 20 AHI, 15 to 30 AHI, we go for CPAP trial, ideally for 6 weeks to 8 weeks. We can also try dental devices if it is suitable for the patients. And if they reject or they are not happy with the dental device or a CPAP, then we advise surgery. And again, for severe more than 30 AHI, CPAP trial for 6 to 8 weeks. They have to reject the CPAP, then we consider surgery. These are the references given. Now, types of surgeries available for OSHs. Bariatric surgery, they are coming up with very interesting papers regarding the bariatric surgery, but this article given in, wrote by Dixon, Scachter and O'Brien in JAMA 2012. This told us that in BMI more than 35, we can go for bariatric surgery, but it improves snoring. That is, the sound is improved, but not apnea. So tissue volume reduction surgery is always needed if you want to reduce the apneas also. The maxillofacial surgeries, they are indicated in congenital or acquired maxillomandibular abnormalities in the first line. And if there is no maxillomandibular abnormalities, then it should be a second line of management when the tissue volume reduction fails. Tissue volume reduction surgery, that is the normal ENT types of surgeries what we are coming into. The BMI less than 35 is the first line of treatment. BMI 30 to 35 to 40, this patient may need also a bariatric surgery. And if there has to be no maxillomandibular abnormalities. Now, the types of tissue volume reduction surgery, there can be nose and nasopharynx surgery, but there are references that it quotes that if we do only nose and nasopharynx surgeries, it improves snoring or obstructive sleep apnea alone in only 16%. So only nose surgery doesn't give much improvement in obstructive sleep apnea cases. But still, in children or in some cases, along with other modalities like oropharyngeal and tongue-based procedures, septoplasty, inferior tapinoplasty, correction of nasal valve, adenoidectomy, these are in vogue. Oropharynx alone is the most common procedures done for obstructive sleep apnea surgery. Alone in less than 50% cases, these are done. There are palatal implants, uvulopharyngoplasty. We are coming into it in a short while. Then lingual base and epiglottis. This is the main cause of surgical failure. We have to think it. We have to keep it in mind that in most of the cases when the palatal surgery fails, so it is sometimes the epiglottis and the tongue base is the cause of that treatment. There are many treatment procedures available, tongue-based channelings. Then there are median partial glossectomies, transferal robotic surgeries are being done nowadays, and partial epiglotectomies if the epiglottic collapse is there, only epiglottic collapse. Now, sites and sites of surgery. So when we are considering a tissue volume reduction surgery, what should be the site of surgery? It is usually a multi-level. There are many methods available. Thanks to Professor Jeb Tam on the first day, he has given a very nice presentation on DICE. Drug-induced sleep endoscopy is considered to be the number one diagnostic procedure to find out what is the site of obstruction or site of surgery till now. But we are conducting a study on combining Muller's. Muller's is a forced inspiration in an awake patient while doing nasal, say, flexible rhinolaryngoscopy. And we can combine it, it can detect a very significant amount of the nose and the upper velar, that is upper palatal blockages. And we can also combine it with the end expiratory pressure. It also detects the tongue base and epiglottic collapses sometimes. If we combine this, if the patient rejects DICE, then it can give up to 70 to 80% data, but still we are going on with the study, and this is not a topic of discussion today. Now, this is the DICE. We are going through the nose now. Yes, here we can see the, this is the palatal level. Now it will get cleaner. Yes. Now we can see that the patient, there is a concentric collapse in the palatal level, that is the velar level. Concentric velar collapse. Here it is collapsing now. This is the salpingopharyngeal folds on the side. This is the soft palate, and this is the nasopharyngeal wall, posterior nasopharyngeal wall. Then we go ahead, go down, see what is there below, because this is not the only level of blockage. Now we are going down. Now here, don't look at the epiglottis, just look at the lateral wall. There are some collapse from the lateral walls also. That is the lateral oropharyngeal collapse. The tonsils are pressing on. So this is a mild lateral oropharyngeal collapse, not a complete collapse of the lateral walls. Now we are going further down. Now there is an, we should look for it. Epiglottis is not totally collapsing by itself. The tongue base is pushing the epiglottis posteriorly. This is an anterior posterior tongue base collapse. Now you will follow it. Here we can see that tongue base, a huge tongue base, it is pressing on the epiglottis and it is collapsing. Yes, this is the DICE. Now this is the Vogt classification based on the DICE. There are 4 levels. Like this Vogt classification is given by Kazarian et al. In European Archives of Otolaryngology 2011. There are 4 levels of collapse assessed, like velum, oropharynx, tongue base, and epiglottis. It can be anteroposterior, lateral, or concentric. Based on it is a complete collapse or a partial collapse, we give numbers. Say no collapse 0, partial collapse 1, total collapse 2. And no collapse, we color that area. When it is 0, we color this area. Okay. So this is the Vogt classification. So by this we do scoring, and then we decide which site to do surgery on. Now we are coming into the oropharyngeal procedures. So what we commonly do, if there is anteroposterior or velar collapse options, anteroposterior velar collapse option only, there is no lateral collapse, no concentric collapse option. The first option is palatal implants, which was first described by Bloxma in say plastic reconstruction surgery 1963. They used silicone implants, but that was, the results were very, say they were not very consistent actually. So later on, recently they came up with the Dacron implants. The company claim it to be a little bit better, but still it can be done with mild epicollapse, that is grade 1 epicollapse, or Vogt 1 epicollapse, and thin palate. If it is a thick palate, it is not of use. So this is the process. A small inserter is there. We can inject the Dacron filaments through it. A very simple process, but not for everyone. Classic UPPP, gradually we are now shifting towards the say soft polyp margin and uvular removal to soft polyp margin and uvular reconstruction and flaps. So we are not removing nowadays the actual UPPP, it is being modified nowadays, but still it has some role in say thick palates, moderate to severe anteroposterior collapse. Then uvula may be removed. It is described by Fujita et al. In Otolaryngology head neck surgery 1981. This is the say removal of this sleeve of soft tissue removed along with the uvula and stitched all together. There can be modifications. So many people make a flap from posterior, stitch it anteriorly. There can be flaps also. Now there is anterior relocation palatoplasty. It can be done in moderate to severe anteroposterior collapse. It can be done in any palate, thin or thick. It's a very good procedure. Here is a block or a rectangular area where the mucosa only is removed, not the muscle. Then it is say stitched posteriorly. So this is the hard palate area, hard palate region, and this square area is here. This is the palatal dimple. We'll show it in our next videos. What is the palatal dimple? And above the palatal dimple, this area is made raw, and it is stitched. Now the oropharyngeal procedure in lateral velar collapse. When there is only lateral collapse, no anteroposterior collapse, we do a lateral pharyngoplasty nowadays. So lateral pharyngoplasty is, there has to be a palatoglossus muscle is cut. Actually do tonsillectomy first, then we cut in the upper part of the palatoglossus muscle here, and we stitch it like this. So posterior this say so palatopharyngeus muscle with the mucosal flap, it is pulled and stitched laterally here like this. So the oropharyngeal opening or the uvular shape becomes rounded to a square shaped. Okay. So this is the lateral. It is described by Kahali in Laryngoscope 2003. It's a very good. It is uvula sparing. We usually do not remove the uvula in this. The palatopharyngeal fold may be cut in the lower end if we want some much release of that fold on everything. Then concentric or velar collapse. This is a very difficult cases to approach actually. When there is a concentric collapse options, like both the anteroposterior and the lateral both are collapsing, then the options are expansion sphincter pharyngoplasty. Expansion sphincter pharyngoplasty is we do a tonsillectomy, we dissect out the palatoglossal fold like this, then we make a tunnel through the palate towards the pterygoid hamulus and give an incision near the pterygoid hamulus here on the submucosal incision, and this palatoglossal muscle is pulled through that tunnel and stitched near the pterygoid hamulus in both the sides. This is called expansion sphincter pharyngoplasty. There are modifications. There are Italian methods of it, there are some Indian methods of it, and there are Dr. Kenny Pang's method. Dr. Kenny Pang is the say father of expansion sphincter pharyngoplasty along with Dr. Woodson. It was discussed in 2007, very good option, but it needs a thick palatoglossal fold. If the person doesn't have a thick palatoglossal fold, we cannot go for an expansion sphincter pharyngoplasty. Next option is, very new option, is Z-palatopharyngoplasty. It was described before this expansion sphincter palatoplasty. Today's topic is Z-palatopharyngoplasty, but we call it zeta because to make a difference with the Z-palatoplasty, which was previously discussed for say cleft palate cases. So any palatopharyngeal fold, so thick or thin, no matter, we can do it. Butterfly submucosal flap is put. We'll show the video after this. Then uvula is split vertically into two. It makes it half. Then one side of the, so two uvular flaps. Then one side of the uvula is stitched to here, and another side of the uvula is stitched there. We'll show in your video later on. But we are not removing the uvula. Still, we are splitting it and making a flap on it and stitching it. This is discussed by Friedman et al. In Otolaryngology head neck surgery 2004, and we should not forget within that et al. There is an Indian name, Dr. R. Vidyasagar. he was also assisting in that, so he was also helping in that, aiding in that paper. So he has started assisting Dr. Friedman, and after that, many people in India are interested in this Z-palatopharyngoplasty, but there are some pros and cons. We are coming into in details. Now, this is the process. First, we are doing into the conventional tonsillectomy. You can use whatever instrument you like. You can use a conventional tonsillectomy, you can do coblation tonsillectomy, radiofrequency tonsillectomy, it is up to you. Whichever method you are comfortable with. Both tonsillectomies are being done. Then after the tonsillectomy, we are marking the points in the palate. Here we are locating the hard palate. Yes, this is the hard palate, soft palate junction. Then we are pointing the plane between joining the anterior pillars. This is not the palatal dimple. There is a plane where the anterior pillars are joining. This is the palatal dimple. The palatal dimple is a point below the muscle fibers, the transverse muscle fibers, and you should not cut the muscle fibers above that point. If you keep the muscle fibers up to the palatal dimple, there will not be any problems. We are marking the incision. This is the butterfly incision. We are using Precise XP Van Dock Cobblator 2 machine. Cobblator 2 is a modified radiofrequency machine. They also claim it to be a say plasma knife technology for resecting. Actually, the machine doesn't cut. The water turns into plasma, and that plasma it actually cutting it. Only the tip cuts, and the other part of the band is used for dissection. But you can use simple cautery, pointed cautery also. It's not like, say, you have to use a Precise XP1 for it, but it is much more, say, gives us a better precision over the job. So this is the incision. The advantage of this is we can do coagulation also. There are switches in that. There are irrigation points. And there are coagulation also, but if you want to do it fast, as we are doing, sometimes we will encounter a little bit of bleeding, but not that much for our conventional, or say if you are doing it with the scissors or cautery method. We are elevating a flap. Only the mucosa is elevated here. The muscle is kept intact, so no chance of any complications later on. Simple bleeders, they can be coagulated along with. Yes, we are extending it towards the midline. And again, it is being extended. The opposite side, say mucosal flap is being made, submucosal flap. Do not worry about this bleeding, because if you are interested in cauterizing, you can cauter it on the same point, same machine. But we are continuing with the surgery actually. Yes, the mucosal flap is being raised. There are two modes in it. Actually, this is a coagulation and a coblation mode. The coblation mode causes evaporation. In the coagulation mode, you can say coagulate the blood vessels. If you do it with, say, scissors and say cautery, it will be faster. But I think with cautery, there is no documented difference between if you do it with a scissor method, cautery method, or a coblation method. But what I personally feel I have done, say that when you are doing it with cautery, it can cause more scarring. because it is not that say temperature is much more, it is the water which is cooling it. And if you are doing it with say cold knife and scissors, the precision may not be that good, and here it will take more time, but the precision is much more. Now we are dividing the uvula. There is a mucosal fold over uvula is being divided vertically. The whole of mucosal flap that is elevated from the palate and up to the epiglottis, that is removed. Here only the tip cuts. If you are trying to cut with the shaft other part, it won't cut. Okay. Then again we are incising the muscular part of the uvula vertically. Into two halves, and now incising on the posterior surface, that is the nasopharyngeal surface of the uvula, the mucosal flap. We are not going inside the line joining the two anterior pillars. We should not go beyond that posteriorly, because otherwise it may cause some stricture. Now we can see the two uvular flaps made on both the sides, and they are gradually being stitched to the say palatal raw areas on the same side, ipsilateral. Uvular flaps are being sutured. Layer by layer, we suture the uvular flaps to the raw area. If you do it carefully, and if you keep the adequate mucosa on the uvula for the reconstruction, then there will not be any raw area left. So more or less this is the surgical technique. Now we will go ahead with our next presentation. Next slides. Now the study details are to identify, our objective with this study was to identify the complications of Z-palatoplasty in India. to find out its effectiveness in the OSA-HS cases. A prospective study was conducted in between 2010 to 2015. It was done in a tertiary private medical center. 25 cases with polysomnography proven moderate to severe OSA-HS cases. We asked them to go for a CPAP trial first, and either they had failed or a rejected CPAP therapy. Then we did a DICE, that is a drug-induced sleep endoscopy, and it proved to be a concentric velar collapse. We selected those cases only, and then these cases underwent Z-palatopharyngoplasty. So we have selected a very specific group. The subjective symptoms, the objective polysomnography parameters were collected pre-operatively and at a minimum of 6 weeks post-operatively, then at 3 months, 6 months and 1 year. Statistical analysis of the results were done mostly based on the SPSS software. Polysomnography, we all know what is the polysomnography. These are the parameters checked during polysomnography, the mild, moderate and severe. The Epworth Sleepiness Scale was assessed pre and post-operatively. It was described by John CMW in 1991. Then there is a visual analog scale. The visual analog scale every patient is given a score between, it is a visual analog scale for drowsiness. The patient has to tell in the last week how he or she felt. 0 was alert to drowsy 100. So patient himself judges what is his score. So there is a wide range of variability. There is a pre-op and a post-op. Now the results, mean Epworth Sleepiness Score we have assessed in pre-op, there was 18.48, 6 week post-op it was 12, then third month 9, so there was significant improvement in 6 week post-op only, and it improved over 1 year. Mean apnea-hypopnea index, it was 28.2. In 6th week, it was 21.16, not significant improvement, but in third month, we could find out that there was a significant improvement. And mean visual analog score, there is 75.52, and in 6th week only, it improved to 49.08. Mean lowest saturation, that is the LSAT level during a polysomnography, 71.6 pre-operatively, improved little bit, 82.36 in 6th week, 85.91 in say third month, but it improved significantly in 6th month post-op. So we can understand from this is mean Epworth Sleepiness Scale and visual analog scale, it improves very fast, but actual parameters that like in the say polysomnography parameters takes time. Mean AHI improves in 3 months and mean LSAT improves over 6 months. So complications are always there. If you do not have a complication, then you did not do a surgery. Phantom uvula syndrome, we have found 8 cases. Phantom uvula, we all know that when you do not have a uvula, if you either cut a uvula or make a uvula flap and stitch it upwards, this patient will complain later on with dryness of the throat. Something is there stuck in the throat, that is called phantom uvula syndrome. So nowadays, before doing these Z-palatopharyngoplasties, we explain these very well to the patients that this is going to happen later on. And you have to cope up with it. If you are okay with it, then only we go ahead with the surgery. Now they gradually learn to cope with those kinds of symptoms post-operative. And temporary nasal regurgitation of fluids, which was there initially, but within 7 to 10 days, it relieved. It was found in only 3 cases. Stitch gave way in 1 case. We had a horrible experience in a case. 4th post-op day, patient tried, after discharge, went back home and tried alcohol. Stitch gave way. So that was a case which we could not give any improvement, but luckily we did not have any voice change. But I should mention here, because in Indian languages there are usually, after Z-palatopharyngoplasty, there are usually no voice change say described till now. But in some literatures we have found that in some Arabic languages or French languages there may be change of some consonants or vowels if you remove or do a uvular flaps. So I am not sure about that. Discussion, all the 25 patients completed 6 weeks follow-up at least, then 22 in 3 months, 18 6 months and 15 1 year. Mean Epworth Sleepiness Score and mean visual analog scale showed significant decrease in 6 weeks. Mean AHI significant decrease in 3 months onwards, and mean LSAT increased 6 months onwards. So Z-palatopharyngoplasty does not give rise to any significant complications apart from phantom uvula. It is also found to be promising in properly selected cases of OSIHS, but a long-term follow-up, preferably with a multicentric trial, is necessary. Thank you. If you have any questions regarding this, I will be happy.
Thank you for the brilliant presentation. Now, entertain questions, comments. Okay.
It's a very nice presentation.
Sure, sure.
Fantastic work coming from Calcutta. Just one or two queries.
Sure.
What was your experience regarding the pain score? You have been using a carburetor, and I know previously you have been using conventional techniques. So, do you find a difference?
No.
Not much.
Not much difference. So I do not. So whenever I am advising carburetor to a patient, I do not comment about pain. Pain is almost same. We do not find any difference between the conventional and a carburetor regarding pain. Pain is almost same. It usually within 7 days it decreases very much, and within 2 weeks it's no pain. Okay. In almost all the technique it is same. So no difference.
But then what advantage does the carburetor give?
First thing is precision. Surgeon's advantage. Okay. Second thing is less bleeding. That also again the surgeon's advantage, because we can do the surgery more efficiently. That's what I say. I just tell them that there will be less intraoperative bleeding and my precision will be better. That is the only thing. Post-operatively, say if you go on follow up all these cases, there are not much difference based on the techniques. Worldwide it is the same data, because no difference based on techniques related to carburetor, related to say pointed, if you have a pointed cautery or a diathermy, or if you are doing it with a basically Friedman and Dr. Vidyasagar did it with a knife and cold steel instruments, and the results are very good. So no difference.
I personally use a lot of CO2 laser for
Yes.
procedures.
Yes.
And I think one advantage what I have seen with CO2 laser is that if you use a cold knife or a cautery, since the collateral damage in CO2 laser is very less, so the edema is much less.
Yes.
So what happens is that sometimes you need a multi-level surgery in this kind of OSA patients. So you can easily get away with a multi-level surgery, because if you use the cautery, sometimes you might have to stage the procedure. You have to do a nasal and a palatal. And
I do it on the same stage, no problem.
I think you must be having the same experience. One point I would like to ask, as far as the regurgitation part is concerned, usually we say that particularly our resection should not reach up to the dimple.
Yes.
The moment that area is reached and you surpass that area, the chances of regurgitation are
Sure,
very high.
sure.
So, do you think that if you carry forward your incision along the uvula a little less than the dimple, you would avoid this?
Yes, you are right. I will answer one by one. First question is about laser. Regarding laser, I used to do lasers in my previous institution where I was attached. I did a laser uveropalaroplasty there also. The results were excellent, but the patient did not follow it up properly. So patient's compliance on all those things were not good. But there are international data against the laser surgeries of palate. Basically, many data, nowadays American Medical Association, that is again a medical association, I am quoting them, that is not a surgeons association, but still they have data that after laser surgeries, the improvement of the snoring, that is the sound, but no improvement of the apnea. Okay, so many say American Medical Association called it, say many mockingly, that laser is a silent killer. It makes the noise less but kills the patient. But in expert hands, it may give significant improvement. That is again in expert hands. There are centers say recommended by the American Surgical Association they told that laser is a very good tool. There are many proponents worldwide. Some people follow laser and some people do not follow. So as I wanted to avoid controversy and all those things, I avoided laser. So actually Indian Indian Association of Surgeons for Sleep Apnea avoids laser for palatal surgery. That is their guideline. Okay, so that is related to laser. Second thing is related to that dimple part. Your muscular resection, that is when you are doing uvulopalatoplasty, the muscle resection should not go above the dimple. But mucosal level incision can extend, no problem. You are perfectly right with that. Okay.
One point I would like to make about the American medical anesthesia that you told. I think that comment would be a little cynical because I think correction of apnea more so depends on the overall planning of the surgery.
Yes.
Because it's very important to have a proper preoperative assessment, a proper mapping of the surgery that you're going to do, and it needs to be individualized according to the patient. No two patients can have the same plan.
Sure.
So if the planning is right and if the execution is proper, I think what I have seen rather apnea totally goes off.
Yes.
Some amount of snoring might reappear in the long run because of the floppiness of the palatal. But anyways,
in my case also apnea improved. Yes, in my case also apnea improved. I have done one single case of LAUP, apnea improved, but still there are data, so I am not going into controversy.
Try to be evidence-based.
Yes.
Any other comments or questions? Thank you, sir, for the excellent
Thank you.
presentation.